so much for joining us today. This is CAPT Holly Van Lew. I'm going to talk a little bit today about the clinical considerations for Zoster vaccine and some of the newest updates that were discussed by our partner Brian Tu from GSK, and talk a little bit more about the implementation pieces at the local level. So we're going to talk about improvement of Zoster vaccination rates and how we can target our providers to do outreach and utilize our tools such as clinical decision support or forecaster to be able to identify individuals who are due for the shingles vaccine. We also want to talk a little bit about post-vaccination adverse events and what we can consider as due to the vaccine potentially based on time course versus when we need to be more concerned, and especially when we're dealing with immunocompromised individuals post-vaccination. And then discussing some strategies to address all vaccine needs at every visit, vaccines at every encounter, and talking a little bit more about some of the expanded recommendations. I didn't talk about it so much in my slides, but there are so many new recommendations that have come out in the last few months regarding pneumococcal vaccines, universal hepatitis B vaccine for every person less than 60. And if you're on this call today and you're less than 60, you need a hepatitis B vaccine if you haven't already been vaccinated. And then, of course, our COVID-19 vaccines, which are quite the topic and a lot of news, a lot of new recommendations for that. And many people need not just their primary series, but also boosters or additional doses if they're immunocompromised. Looking at our target populations, age-based recommendations would be that any person 50 and older needs the shingles vaccine, whether you've had a history of shingles, whether you recall having chickenpox as a child. Everyone 50 and older should be offered the shingles vaccine. One of our tools that we can use in our electronic health record is that our forecaster does predict our Zoster vaccine needs for individuals in this 50 and older group. So we can rely upon the forecaster and use that tool when we're assessing someone's immunization status when they come in for a visit. The newest recommendations that are risk-based for those individuals 19 to 49 who are immunocompromised is not incorporated in the forecaster at this time. That's because immunocompromising conditions are quite complex. They can be temporary or permanent. It can be variable based on the severity of disease, the medication you're taking, or even the dose of the medication that you're taking. So immunocompromising condition is something that we really need to be able to evaluate at the time of the patient's in clinic and assess whether they are fully immunocompromised or considered immunocompromised, or if they're immunocompetent at the time and have the opportunity or have the risk of becoming immunocompromised if they're starting a new medication soon. We are doing some ongoing work, working with Surium and others, looking at the forecaster, looking at some of the high-risk forecaster pieces in consideration for can we use some of the programming that's been done with COVID-19 vaccines for identifying immunocompromised individuals and potentially use that in other scenarios such as shingles vaccine, but right now that's certainly in the future considerations piece. For a Zoster vaccine, really the biggest piece is talking to the high-risk providers and patients. So doing outreach, it takes a person, it takes an advocate, it takes a champion, and we can have these champions across all of our clinics within our facilities, but reaching out to individuals in our rheumatology clinics, dermatology clinics, oncology clinics, and others in reaching out even to our dialysis centers to double check if they're screening for vaccine to see if individuals are due for their shingles vaccine, if they've completed that series, or if they're being at least offered it. They can, at a minimum, have their information reviewed and referred to receive vaccine. They could either receive that vaccine at the IHS facility, at the specialty provider, or in the community, at a community-based pharmacy clinic is another option. So we know that these specialty providers are seeing immunocompromised patients more frequently, and taking that time to talk with the specialty providers about that increased risk, showing them some of that data and encouraging them to have that conversation, not just the provider, but also all the ancillary staff as well, putting that on their priority list to evaluate whether these patients are at risk. We also want to look at individuals based on their drug treatment. So working with pharmacy, working with our informaticists, trying to generate some reports to identify these patients via drug therapy, and then always trying to track and trend the data. So at Phoenix Indian Medical Center, they've recently increased some advocacy for Shingrix and encouraging addressing the vaccine needs for all vaccines, but of course for Shingrix, and we've been tracking it, and our site is excited to see that she's noticed about a 6% improvement in just a matter of a few weeks. That's a lot. That's a big number. So tracking the data, reaching out to the providers, creating some fun competitions, or at least recognizing and saying out loud that you're recognizing the extra effort that these specialty providers and their ancillary staff are putting in is really important. One of the most critical things that we can do is just incorporate vaccine review into every bit of routine care. So putting it under healthcare maintenance and asking our medical providers, our pharmacists, our nurses, our clinical educators to address vaccines at every encounter. So looking into pre-visit planning, utilizing the forecaster, and right now, that, like I said, the forecaster is working for 50 and older, but is not available for those immunocompromised people 19 to 49, but utilizing our clinical tools and encouraging everyone to ask, assess, and advise, just like we do for tobacco cessation and other things. We're using these tools, and either they can administer or refer the patient to a vaccine clinic. It's really critical that we find those vaccine champions and thank them every day, every minute that we can, celebrate all their activities, and call them out, make them a certificate, give them a candy bar, do something exciting because it is a lot of extra work to constantly be evaluating vaccines at every visit, but it's the right thing to do to provide prevention for these folks. We have these missed opportunities for prevention that can lead to severe disease, especially our immunocompromised individuals. And we really want to be able to offer that prevention to them any opportunity we have. The other thing I wanted to talk a little bit about was reactogenicity with the shingles or Zoster vaccine. We know that the shingles vaccine, as Dr. Chu went over, does create a great and strong, robust immune response. And part of that is due to the potent adjuvant that's available and used by the Zoster vaccine. But we know it can cause some of those common side effects, as Dr. Chu mentioned, the local and systemic, and even grade 3 reactions, which means that they're unable to do their normal activities. They may call into work, they may not be able to help with grandkids, or those kind of things. It's important to know that time course, that side effects will onset usually within that 24-hour time period after vaccination, but they will be gone at 72 hours post-vaccination. And that's an important communication, something important to talk with our patients, that if you continue to have ongoing side effects or symptoms after 72 hours, that's not normal and you should seek care. So sometimes these side effects can be confounding and overlapping. They can overlap with other diseases. They can overlap with COVID and other infections. And so Zoster vaccine post-vaccination side effects can include fever, fatigue, chills, headache, muscle aches, and some GI symptoms as well. But those should abate at that 72-hour period. If anyone has additional side effects or additional symptoms that aren't consistent with vaccination, such as sore throat, shortness of breath, loss of taste or smell, or cough, we would not think of those as being attributed to the Zoster vaccine. And especially in our immunocompromised individuals, if someone walks in our emergency room and they come in with fever, aches, chills, and fatigue, we may work them up for a lot of different things, not just COVID. We may work them up for all kinds of things and take a lot of time to assess what's going on in their bodies. So it's important to have patients be aware that these side effects are normal, and if they're not sure, they should be given the opportunity to contact someone before seeking care and utilizing the emergency department. We actually took the effort to make a post-vaccination handout for all patients. Here on this handout, we talk a little bit about who gets shingles vaccine. We have the dates that you can fill in for dose 1 and dose 2, which is really important, and a visual reminder for the patient that they'll need to come in for that second dose. There are common side effects listed here, as well as what to do to manage those side effects. How do we mitigate those? So we can use antipyretics and pain relievers such as Tylenol or ibuprofen, as long as the patient doesn't have any adverse or have any reason why they can't take it or allergies. But more importantly, we want to provide them a phone number where they can contact someone, they can reach out before they come in to seek emergency care, just in the case that it's something very minor and it's just a side effect that's common and expected for shingles vaccine. I usually try to provide them a written reference, not just this handout, but also the vaccine information statement, and kind of highlight what are the common side effects, because most people who get Shingrix feel pretty cruddy for the next day or two or after vaccination. So it's important that they know this is normal and this is expected, but you know, when might they need to seek additional care or input? And I think that's it for my section.